Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, I'm Elaine Kawili, and I'll be giving you a basic introduction to MR-Guided Interventions. Here are my disclosures. MRI has been used to guide procedures as early as the 1990s. However, it has not been widely adopted due to a number of factors, including limited accessibility, lengthy exam time, and a lack of MR-compatible equipment. However, recent improvements have decreased several of these limitations, and interventional MRI has been established for a variety of indications where MRI greatly enhances the procedure. This is true for breast biopsies and prostate biopsies. The application of MR to prostate biopsies has been varied. For example, it has led to the development of MRI ultrasound fusion biopsies typically performed by urologists, as well as the development of MRI-guided in-bore biopsies, which can be performed using a variety of approaches, such as a transperineal approach, typically requiring general anesthesia, as well as the transrectal and transgluteal approaches, which we perform, which can be done with moderate sedation. We perform our procedures on a 0.55 T magnet, which offers several features which are quite beneficial for in-bore procedures, such as an 80 centimeter bore diameter. This is larger than many scanners, and this increased room allows us easier access for needle manipulation. With this scanner, we have reduced susceptibility artifacts and reduced metal distortions, as is nicely demonstrated in the example below in this patient who has a left hip prosthesis and was imaged on both the 3T and 0.55 T magnet. Now on the 3T image, we can see significant artifact from that left hip prosthesis, which obscures a large portion of the prostate gland, which really is not an issue on the 0.55 T magnet image. We use flexible multi-purpose surface coils, which allow us to contour the coils to the patient's anatomy. We also use MR-compatible needles and biopsy devices. It is important to remember that these needles and devices do not have the same tensile strength as stainless steel needle. However, when performing MR-guided procedures, we very much prefer to use these MR-compatible needles, and the reason why is shown in this next example. On your left, we have an image of a 25 gauge stainless steel needle, and compare that to the image on your right, where we have a 25 gauge MR-compatible needle. And these are both imaged on a 0.55 T magnet. Now, needles are seen as a signal void created by susceptibility artifact, and this example highlights several important features, one of which is that artifact may actually obscure nearby adjacent critical structures such as vessels, which if traversed could cause complications. In addition, it's very difficult to know exactly where the tip of the needle is within the artifact, making further manipulations of this needle more challenging. Visibility of the needle also depends on the strength and the orientation of the magnetic field. On the example below, note the different appearances of the needle on both the sagittal and axial images, even though this is the same needle in the same patient performed during the same procedure. Here is one of the procedures that we have performed on the 0.55 T magnet. This is a 59-year-old male with cerebellar hemangioblastoma who was found on the ground with loss of consciousness. Imaging showed new intracranial lesions as well as a right psoas mass, which is seen on the images above. This mass is T2 hyperintense with minimal enhancement. This patient also underwent a same-day contrast-enhanced CT in which no abnormality was found in that right psoas muscle. In this next image, you can see us approaching the target, and pathology revealed histiocytic inflammation without evidence of malignancy. This patient also underwent a subsequent PET-CT, which showed no significant uptake in that right psoas muscle, likely indicating inflammation secondary to the fall. I'm going to spend the rest of my time discussing prostate biopsies, since that is the bulk of the procedures that we do. All patients undergo a diagnostic MRI, which we review. The procedure is performed with moderate sedation and local anesthesia. We use a 16-gauge coaxial needle, which we advance through the soft tissues and adjust via intermittent imaging using the freehand technique. Once the target is reached, we take a minimum of at least 2 samples using an 18-gauge device. Patients are then monitored for several hours and then discharged home. This is all particularly true for our transgluteal percutaneous approach. Here's one of the prostate biopsies that we performed. Earlier imaging from May of 2017 showed an 8 mm PIRADS 4 lesion in the right peripheral zone, and this was in a 62-year-old status post APR for ulcerative colitis. The patient then underwent a transperineal fusion biopsy, which came back negative, and he subsequently underwent surveillance. He returned in December of 2021, where we see that the lesion has increased in size. He then underwent another transperineal fusion biopsy, which came back negative. He returned in July of 2024. Imaging showed that the lesion has increased in size, also nicely confirmed on ADC imaging, and now there's the suspicion of extracapsular extension. He then presented to us for biopsy. We placed the patient in the prone position and placed skin markers, which you can see on both the sagittal and axial images. The skin markers are used to identify a needle entry site. Once a site is identified, the skin is prepped and draped, and the overlying soft tissues are anesthetized with lidocaine. On the illustration on your right, you can see the typical placement of our surface coils, which are separated for approximately 2 to 3 centimeters to allow for needle entry. We then systematically advance the needle to the target and obtain several samples. Now, each core is individually evaluated by our pathologists that determine the volume involved with malignancy. So for that last example, there were 3 cores, and the volume involved with cancer ranged anywhere from 60 to 80%. In addition, a Gleason 1 and Gleason 2 pattern, as well as Gleason score and grade group, are reported for each core. And just to review, for this example, the overall cancer had a Gleason score of 8, grade group of 4, indicating a poorly differentiated, highly aggressive, high-risk lesion. Here's another patient that we sampled, a 74-year-old with elevated PSA. Imaging showed a 7 mm PIRADS 4 lesion involving the left apical peripheral zone, also nicely seen on ADC imaging. You can see us approaching the target, and pathology was consistent with cancer, with a max Gleason score of 6, max grade group of 1, indicating a well-differentiated low-risk lesion. Here's another example of a patient we sampled, an 85-year-old with rectal pain. CT showed enlarged lymph nodes and sclerotic lesions. MRI showed a large lesion involving the right peripheral zone with extracapsular extension involving the right neurovascular bundle, seminal vesicle, and anterior rectum. You can see our needle approaching the target. Pathology was consistent with cancer with a max Gleason score of 10, grade group of 5, indicating a poorly differentiated high-risk lesion. Here are the imaging sequences that we have tried. All patients undergo a T2-weighted turbospin echo technique for lesion localization. During the procedure, there are a variety of different sequences that can be used. Currently, we are using a GRAPPA sequence, a form of parallel imaging, which is not listed here, and we have preferred using this due to shorter acquisition times. We've compared our in-bore biopsy approaches, transrectal versus transgluteal approach, and as you can see, there was no significant difference in the mean procedure duration between the 2 approaches. It is important to note that these procedure times actually include research sequences and also reflect our attempts at image optimization, as well as some of the challenges we've encountered with our biopsy equipment. Currently, our mean procedure duration for a targeted lesion is 50 minutes. The mean time to first core was slightly longer for the transgluteal approach. The mean distance to target was significantly longer for the transgluteal approach, 3 centimeters transrectally, 11 centimeters for transgluteal biopsy. We encountered no immediate complications, no bleeding or infection for either approach. A few lessons learned. This is a 70-year-old with elevated PSA who had undergone several negative biopsies. Imaging showed a large left hip prosthesis, and the urologist had asked us to sample a right peripheral zone lesion. We placed the patient on the scanner, and we saw a 20 mm T2 abnormality in the left anteromedial peripheral zone, not seen on prior MR. Here you can see us sampling the lesion, and pathology was consistent with cancer with a max Gleason score of 7, grade group of 2. So it is important to scrutinize all images because new sites of disease may be encountered, which may require sampling. On the other side of the spectrum, here's a 61-year-old elevated PSA. Imaging showed a 5 millimeter Pyrex 4 lesion involving the left peripheral zone. We placed him on the scanner and saw that there was no lesion to access, and so no biopsy was performed. Before the patient left, we did place him on the 3T scanner, which confirmed that there indeed was no lesion to access, and this lesion likely represented resolving prostatitis. Another lesson learned in a 69-year-old elevated PSA who had undergone a negative fusion biopsy. Imaging showed a large right transitional zone lesion. You can see our needle approaching the target. However, upon further manipulations, we noted it was more difficult to advance the needle appropriately. Additional imaging showed significant curvature of that needle, which we attributed to increased distance target, as well as decreased tensile strength. This coaxial needle had to be removed and replaced, and eventually we were able to obtain adequate specimens consistent with cancer with a max Gleason score of 7, grade group of 2. So in conclusion, MR-guided interventions are feasible using a 0.55T magnet and can be done safely with minimal complications. These procedures, particularly the transgluteal approach, is comparable to CT-guided procedures and thus can be easily adopted by radiologists who are familiar with this technique. In the future, we hope to improve our procedure times, perhaps with MR fluoroscopy. We hope to find improved MR-compatible instruments in regards to visibility and strength. And of course, we'd like to be able to apply these techniques to other sites within the abdomen and pelvis. Thank you.